Hello and welcome. Today we're delving into a specific kidney disorder known as type 2 renal tubular acidosis, often referred to as proximal renal tubular acidosis or RTA. So what causes this condition? Type 2 RTA primarily arises from a defect in the proximal tubules of the kidneys. This defect impairs their ability to reabsorb bicarbonate back into the bloodstream. This can be caused by genetic mutations affecting bicarbonate transporters, medications like carbonic anhydrase inhibitors or outdated tetracyclines, heavy metal poisonings such as lead, and systemic diseases including multiple myeloma, amyloidosis, and Sjogren's syndrome. It can also be seen in association with Fanconi syndrome, a more generalized dysfunction of the proximal tubule affecting the reabsorption of various substances. Let's break down the pathophysiology. Normally, the proximal tubules efficiently reclaim bicarbonate from the glomerular filtrate, preventing its loss in urine. In type 2 RTA, this reabsorption process is faulty. Bicarbonate is essentially leaked into the urine. This loss of bicarbonate leads to a decrease in blood bicarbonate levels, resulting in metabolic acidosis. The body attempts to compensate for this acidosis through various mechanisms, including buffering systems and increased respiratory rate to exhale more carbon dioxide. However, these compensatory mechanisms are often insufficient to fully correct the acid-base imbalance. The chronic loss of bicarbonate can lead to various downstream effects, including electrolyte imbalances and bone disease. The exact prevalence of type 2 RTA is difficult to determine as it's often associated with other underlying conditions. It's rarer than distal or type 1 RTA. It can affect individuals of all ages, but its occurrence may vary depending on the specific underlying cause. For example, RTA associated with Fanconi syndrome is more likely to present in childhood, while RTA caused by certain medications may be seen in adults. The signs and symptoms of type 2 RTA can be varied and depend on the severity of the bicarbonate loss. Common symptoms include fatigue, muscle weakness, bone pain, and failure to thrive in children. The chronic acidosis can lead to bone demineralization, resulting in rickets in children and osteomalacia in adults. Patients may also experience frequent urination, dehydration, and growth retardation in children. In severe cases, kidney stones and nephrocalcinosis can develop. Diagnosing type 2 RTA involves a combination of clinical evaluation and laboratory testing. Blood tests will reveal low serum bicarbonate levels and an acidic blood pH, confirming metabolic acidosis. Urine tests are crude to demonstrate a high fractional excretion of bicarbonate, indicating the kidney's inability to reabsorb bicarbonate effectively. Further testing may be required to identify the underlying cause of the proximal tubular dysfunction, such as urine protein electrophoresis to look for multiple myeloma or testing for autoimmune diseases. While there aren't distinct subtypes of type 2 RTA in the same way as other forms of R, it is important to distinguish between isolated proximal RTA and RTA that is part of a more generalized proximal tubular dysfunction, such as Fanconi syndrome. In Fanconi syndrome, there is also impaired reabsorption of glucose, amino acids, phosphate, and other substances, leading to a more complex clinical picture. The primary goal of treatment is to correct the metabolic acidosis. This is typically achieved through oral bicarbonate supplementation. The dosage is tailored to the individual patient and adjusted based on blood bicarbonate levels. In cases associated with Fanconi syndrome or other underlying conditions, specific treatments for those conditions are also necessary. Regular monitoring of electrolyte levels, kidney function, and bone health is essential. Sometimes potassium supplementation is necessary to prevent low blood potassium, which can occur with bicarbonate therapy. Unfortunately, there aren't specific preventative measures for type 2 RTA, particularly in cases caused by genetic mutations. However, avoiding nephrotoxic medications and managing underlying conditions like multiple myeloma or autoimmune diseases can help prevent or minimize the severity of acquired cases. The prognosis for individuals with type 2 or 2A depends largely on the underlying cause and the effectiveness of treatment. With appropriate bicarbonate supplementation of any underlying conditions, most patients can lead relatively normal lives. However, untreated or poorly managed RTA can lead to chronic kidney disease, bone disease, and growth retardation in children. Research continues to explore the genetic basis of RTA and develop more targeted therapies. For example, there are ongoing studies investigating the potential of gene therapy for certain inherited forms of RTA.